Hello, good morning, friends. I think all of us have been doing a wonderful cataract surgery, but in spite of that, some of the patients may be unhappy and no fault of ours, but whether because of healing, whether because of dry eye, or whether because of inflammation, and there has been a lot of confusion whether to give the peri-operative antibiotics or not, for how many days we should give the antibiotic, for 1 day, 3 days, 5 days, only on the day of operation. So in this session, of course, we will be focusing primarily upon what we should do and how to go about it. We are not talking about the surgical skill of the surgeon, but we will be discussing what all methods we should adopt so that we do not have any of these problems post-operatively. That means, of course, as an eye surgeon, we are more scared of infection than anything else on the earth. That's the only reason probably we do not mostly operate both the eyes simultaneously. If
But there is a society,
huh?
Harman, there is a society of bilateral cataract surgeons.
Yeah. So they have formed a society of bilateral cataract surgeons in USA, primarily because over there OT charges are very heavy. So they want to curtail on that. And the patient is of course more comfortable putting the drops in both the eyes at the same time. So rehabilitation period is reduced and cost to the patient or to the insurance company is reduced. But given the scenario, I'm not particularly very fond of doing the bilateral cataract simultaneous cataract surgery. I rather prefer a sequential cataract surgery. There are two reasons. One is, of course, if there is any breach in the infective measures, then you are really into the trouble. You can't, even in the USA, you can't defend it in the law of court. That means if something goes wrong, doctor will be sued and there is no explanation for this why you have done both the surgeries.
Dr. Hemlata, please join us here.
And another is that because most of the time the biometry even now is not 100% accurate. And when you operate the sequential surgery, you can decide after doing one eye, you can fine-tune the IOL choice in the second eye, whether you want to keep the patient a little myopic or you want to keep the patient a little.
So Dr. Rajesh has come and I am joined by Dr. Harbanslal. You have already heard Dr. Hemlata, a prolific, very, very fine cataract surgery surgeon she is, and honestly she has operated upon, most of my family members. So whatever my wife sees today is primarily because of Hemlata. Thank you, Hemlata, for joining us. You see, the session itself is known as cataract surgery medical management, which is a misnomer in the sense there is no medical management for cataract. But what we are going to talk about is some perioperative and peroperative kind of issues which can augment or increase your success rates in cataract surgery. So I think we'll not wait for the first speaker and we'll go ahead with Pratik Tiotia and Nepafinac in pain and inflammation post-cataract surgery. You see, all surgeries excite some degree of itis, some degree of inflammation. Any surgical trauma, anywhere in the body, in fact, creates some inflammation. And in the eye, this pain inflammation may be more bothersome for the patient because patient has been promised that dropless, painless surgeries. So there may be some patients who have pain, inflammation in the cataract surgery, post-cataract surgery, and whether we should be regularly using Nepafinac or select patients or some high-risk patients, and what is the regimen, what should be following. You see, a lot of us, give antibiotics for 1 week, then steroids for tapering doses for a month or so, then start Nepafinac for 4 to 6 weeks. But there are some high-risk patients like uveitis or diabetics or CME patients or diabetics. So they may require Nepafinac for a couple of weeks and months. So we have with us Pratik Tiotia, again a very prolific, very fine cornea and cataract surgeon with us. And he will tell us the role of Nepafinac and how he also uses it in his own practice.
So I'll invite Dr. Rajesh Sinha to be on the desk, please. He is a panelist with us and is a professor at RP Center.
Good morning, everyone. At the outset, I would like to thank the organizers of this conference for giving me this opportunity, particularly Elvis sir. Because of him, I could visit Amritsar. So I would be speaking on role of Napafinec in pain and inflammation management post-cataract surgery. So longitudinal aging study in India, wave 1, they found that the overall prevalence of cataract among the study population was 14.85%, and record cataract surgeries in India over more than 8 million successful surgeries are performed. So ocular inflammation is common following cataract surgery. Inflammation can cause post-operative pain, photophobia, if untreated, can lead to increased IOP, posterior capsular opacification, CME, and decreased visual acuity. So management of post-surgical pain and inflammation, corticosteroids and NSAIDs, they play the main role. Corticosteroids, its mechanism of action acts by blocking arachidonic acid release by inhibiting phospholipolysis A2, reducing the synthesis of prostaglandins, thromboxanes, and eicosanoids. NSAIDs inhibit prostaglandin release by blocking the cyclooxygenase enzyme that convert arachidonic acid to prostaglandins. So corticosteroids, although they are the gold standard, but they have some limitations because they have some adverse effects such as increased IOP, increased susceptibility to infection, and slow corneal wound healing. Prolonged use of steroids can lead to development of glaucoma, visual acuity defects, and loss of visual fields. So NSAIDs, they are safer alternatives to corticosteroids. Benefit of NSAIDs over corticosteroids: stabilization of IOP, provision of analgesia, reduction in the risk of secondary infections. NSAIDs are indispensable in post-cataract surgery management because they are used to manage inflammation, CME, and post-operative pain, provides optimal surgical outcomes in both routine and complex cataract procedures, maintains intraoperative mydriasis, and reduces both intra and post-operative ocular pain. So Napafinec, which is used for pain and inflammation management post-cataract surgery, indications are for the treatment of pain and inflammation associated with cataract surgery. Mechanism of action is Napafinec is a prodrug. It penetrates the cornea where the hydrolysis enzymes, which are present in vascularized intraocular tissues, they convert it into active molecule Amphinec. Amphinec inhibits prostaglandin H synthetase, that is cyclooxygenase enzyme that is involved in prostaglandin production. Dosage is 1 drop TID starting the day before surgery, on the day of surgery, and for 2 weeks post-operatively. Administer an extra dose 30 minutes to 1 hour 20 minutes before surgery. So Napafinec is the prodrug NSAID formulation, and it is unique as it is not a free acid like other topical NSAIDs. Other topical NSAIDs, due to their water solubility, they have limited corneal epithelial permeability. Napafinec, being an unionized drug, is readily absorbed across the cornea at higher tier pH levels, and the preservative bag which is used against it enhances corneal penetration and increases corneal absorptions. So Napafinec 0.1% provides the higher cure rate and pain-free recovery. A study comparing Napafinec 0.1% in reducing the incidence and severity of inflammation and pain following posterior chamber IOL implantation. The primary endpoint was percentage of patient cured of ocular inflammation at day 14. One arm received Napafinec and the other arm received vehicle, and a cure was defined as aqueous cell score plus aqueous flare score 0. Patient was considered cured if they remained free of ocular inflammation at all subsequent visits. So Napafinec 0.1% effectively prevented and treated inflammation and pain after cataract surgery with a higher cure rate and more patient pain-free at each post-operative visit from day 1 to day 14. So benefits of pre-operative administration of Napafinec 0.1%. So this study evaluated the efficacy of pre-operative administration of topical Napafinec 0.1% on anterior chamber flare following uneventful cataract surgery in healthy patient. Clinical outcome measures were best corrected visual acuity, intraocular pressure, retinal central foveal thickness, and aqueous flare. So the outcome was pre-operative administration of topical Napafinec 0.1% is safe and effective, significantly reducing inflammation in the early post-operative period, 1 month compared to the untreated group. So another study which evaluated the analgesic effect of Nepafenec. So in one arm, patient received Nepafenec 0.1% plus topical anesthesia. In the other arm, patient received placebo plus topical anesthesia, and the endpoint was patient pain perception. Patients were informed about the visual analog scale and verbal pain scale immediately after the surgery. So pre-operative Nepafenec 0.1% can reduce pain and increase patient comfort during cataract surgery and is more effective than topical anesthesia alone. So combining Nepafenec with steroid, so it may be a better alternative to corticosteroids. So systemic review and meta-analysis showed that NSAIDs and combination treatment showed a lower incidence of CME. NSAIDs showed lower central macular thickness. NSAIDs had favorable flare values, and combination treatment showed favorable best corrected visual acuity. So both NSAIDs alone and NSAID steroid combination treatments are more effective and safer than corticosteroids alone for the post-cataract surgery management. So addition of Nepafenec to dexamethasone enhances anti-inflammatory effect. So this study compared Nepafenec plus dexamethasone in one arm and dexamethasone plus placebo in another arm. And statistically, a significantly higher number of patients in the Nepafenec group reported being pain-free during the day after surgery than the control group. So number and percentage of patients with macular swelling of more than 10 micron were evaluated 3 weeks and 6 weeks post-operatively. Nepafenec group had less macular swelling than the control group, and the differences were statistically significant for primary and secondary outcome measures. A higher percentage of patients in the Nepafenec group than in the control group reported having no ocular discomfort or photophobia 1 day and 3 weeks post-operatively. So combination of Nepafenec and dexamethasone reduces subclinical macular swelling and inflammation along with subjective complaints, suggesting it is an effective anti-inflammatory regimen following cataract surgery. So combining Nepafenec with prednisolone again is more effective in controlling ocular inflammation than prednisolone alone after emulsification. So this group had group 1 which received prednisolone 1% and the group 2 which received Nepafenec and prednisolone 1%, and clinical outcome parameters were anterior segment inflammation and CME. So addition of Nepafenec to prednisolone significantly reduces intraocular inflammation more than prednisolone alone after phacoemulsification in the early post-operative period. So main takeaways are Nepafenec, an unionized drug, is readily absorbed across the cornea at higher TRPH levels. It also contains BAK, a corneal permeability enhancer, as a preservative. Nepafenec prevents post-cataract surgery inflammation and pain with a higher cure rate and more patients being pain-free. Pre-operative Nepafenec significantly reduces inflammation in the early post-operative period compared to the untreated group. Pre-operative administration can also reduce pain and increase patient comfort during cataract surgery. Combination of Nepafenec and dexamethasone reduces subclinical macular swelling and inflammation along with subjective complaints. Addition of Nepafenec to corticosteroid significantly reduces intraocular inflammation compared to prednisolone alone after phacoemulsification surgery. Thank you.
Thank you, Dr. Pratik. I would like to know from the audience, is there anybody who is not using anti-inflammatory perioperatively? Do all of you use anti-inflammatory perioperatively? Dr. NK? So is there anybody who is not using, if not using for any reason for that?
So, yes.
Pratik, I think he has a point, because if you see the inflammation ka cascade, steroids act at a very high level.
Yes, at a higher level, yes.
And COX inhibitors act at a lower level. So अगर ऊपर ही बंद कर देंगे तो नीचे का जरूरत नहीं होना चाहिए.
Some inflammation goes down, so they will control part, and the Nepafenec or NSAID, they will further block the prostaglandin.
So these are slightly loose words that some inflammation goes down, some का मतलब 5%. What I am trying to say is that you see, most of us used to do steroids first. After 2 weeks, once we are tapering and reducing and stopping, add Nepafenec to take care of the because the advantage is that it takes care of the prevention of CME also.
So a study conducted in Europe, they found that adding NSAIDs post-operatively for 2 weeks reduces the incidence of CME, particularly in diabetic patients. So in those cases, it is mandatory. Plus, you can increase the patient comfort, as I showed in studies.
Let's ask Hemlata, what do you say?
So there's so many studies that show that the combined use of non-steroidal anti-inflammatory with steroid have more efficacy in reducing the macular edema, incidence of
Plus,
macular
nowadays we are doing a lot of femto surgery, so adding pre-operatively and before surgery will prevent the intraoperative meiosis also,
Meiosis
sir.
also.
Because after femto, we see that many cases they come with 2 mm pupil size. So if you start pre-operatively NSAIDs,
What is your take on 0.1%, 0.3%?
yes,
OD
sir.
dose is more
So
compliant.
both are effective, but it has been found in studies that 0.3% gives more comfort, more anti-inflammatory effect, and less lid swelling at the end of 1 week post-surgery compared to 0.1%.
No, before Harbanslal Panchi said, Rajesh, what is your take? What is your routine?
I feel that, I mean, based on the literature and based on our own experience, I feel that NSAIDs may not be required in all the cases, but in high-risk cases like cases of healed uveitis, patients of diabetes, patients who had a PCR, patients who had complicated, prolonged surgeries. In all these cases, I think addition of NSAID is Nipafenac is very useful.
So you don't give in routine cataract surgery?
Not in all cases, but yes, in all these high-risk cases, yes, I do add. Additionally, if I'm using low-potency steroid, there are some patients who who are steroid responders, or in some of the myopes wherein I don't want to take a chance. So I do give low-potency steroid. Therein, I add once daily high concentration Nipafenac.
So do you use this pre-operative non-steroidal in all the high-risk patients?
Yes.
And how many weeks prior to the surgery you start?
3 days before. Actually,
3 days.
Ideally you can start a week before, but 3 days is good enough.
You prefer 0.3 or 1.3 if you start 3 days prior?
See,
And which one is better?
I see. If you're using 0.1, you can use it 3 times a day. So, being a cornea person, I would prefer putting once daily because it will have less surface toxicity. So, once daily is preferable as far as I am concerned.
So that's why my next question for Dr. Prateek. He's a cornea person. So how friendly are these drugs for the cornea? Because I've seen a lot of patients developing SPKs post.
So what I have noticed is with Navanac and Ilevro, compared to the generics, they are more cornea friendly. Generics, they cause more SPKs, maybe the formulation is different or maybe the method of preparation is different. But Navanac and Ilevro, I have not found any corneal toxicities. And we have to be careful in patients who have very severe dry eyes.
Quite a confusing situation now.
Yes.
So you have to punch it now. You have to
So
tell
I
what is
think
the-
that's a very difficult proposition to keep on changing the medication from one patient to another patient, because this medication is explained by our staff. And it's better to have a standard medication protocol for first few days. That means when the patient is operated and you see next day or 2-3 days, and then you can stop it or you can prolong it. Because if some patient you are giving, some patient you are not giving, this stop is going to be totally confused. So my protocol will be standard for all of them. Get the Nipafenac for 1 week, and there is absolutely no inflammation. And if there are any signs of SPKs developing over there or dryness developing over there, or there are symptoms of the dryness, then of course I will try to stop most of the medication as early as possible. So this is very difficult to keep on changing the medication. So the standard protocol is that all of them get it for 1 week, and then if required we can prolong it or shorten it.
So my question to Dr. Namta is, in which cases you will avoid Nipafenac post-cataract surgery?
So cases of dry eye, I would
Yes.
avoid. Cases where I fear that there might be compromised ocular surface, like Steven Johnson, ocular cicatricial pemphigoid, those cases I will not give NSAIDs at all.
With corneal scars also, ma'am.
With corneals, wherever there is any
So
corneal or ocular
any
surface
corneal
pathology,
any corneal
yeah,
pathology,
so
dry
there
eye,
I
you
will
should-
not give neperphenate.
So I think this is a very good message Namrata has given. And
Any ocular surface disorder and any patient with a significant MGD who has a risk of, ocular surface disorder and SPKs, it should definitely be
So
avoided.
ocular surface disease, any corneal or ocular surface related problem,
Yes.
which would include everything.
So I think let's move on. We have a reasonable consensus now that Napafenac do help in patients who have corneal pathologies, dry eye, MGD, you should avoid them. But specifically in high-risk patients, uveitis eye, diabetic, PCR, or prolonged surgery where you have fiddled with iris too much or some mishap has happened, then definitely they are indicated for long time. Long means at least for 3 months. And specifically if patient has had CME in the other eye, then in any case, Rajesh, we should be definitely using them. So with this, I think we'll move on. And there was some controversy raised about generic versus, the standard innovator kind of molecule. And people feel that if you are using the even innovator, the possibility of SPK developing is much less. So we move on to another relatively controversial or maybe now established role of moxiflox in perioperative, because you see antibiotics have been used and misused, causing resistance in the entire community. In fact, whether it is definitely required in all the patients or in against select patients. You see, apart from moxiflox, there are a lot of other antibiotics which have been studied to prevent infection. Cefuroxime from Europe and Vanco from Canada. So these 3 antibiotics have being studied quite a bit. But what Namrata will tell us about is the role of moxiflox, because there's a lot of studies. Namrata herself has done one of the largest high volume study, as well as Arvind Hospital also conducted. The difference was Arvind's study was retrospective, whereas the Namrata study is a prospective study. So let's hear Professor Namrata Sharma about role of moxiflox in perioperative sterilization.
So thank you, sir. I would be talking to you about role of intracameral moxifloxacin in prevention of post-cataract surgery endophthalmitis, and there are no financial or proprietary interests. And although post-cataract surgery endophthalmitis is decreasing over the last decade, but it is still the most ominous complication. As far as prophylaxis is concerned, we give preoperatively topical antibiotics. Povidone iodine and intracameral antibiotics have been advocated intraoperatively, and postoperatively one can give topical antibiotics. Globally, coagulase negative staph is the most commonest cause of endophthalmitis along with staph, but in India I think gram negative and fungal infections are also quite common. If you look at the ASCRS endophthalmitis prophylaxis survey, the respondents who would use the formulation is as shown, and in 2021, 66% responded said that they actually use it, vis-a-vis 2014, where 84% said that if there was one formulation approved, they will use it. This is the survey of 2021 ASCRS endophthalmitis prophylaxis survey, and in this, vancomycin was being used by 6% of the respondents. And reasons cited for those not using intracameral antibiotics was compounding problem, unconvinced of the need, and also they said that there would be increased adoption of intracameral prophylaxis to the tune of 93% if there was a drug which was available. So if we look at the drugs between cefuroxime, moxifloxacin, vancomycin and cefazolin, moxifloxacin is now available, which can be given intracamerally, and other drugs have been tried over the last few years. The advantage being that the preparations are available commercially, wide spectrum of action is there, and has concentration dependent killing. Now, this was the ASCRS study of prophylaxis of post-op endophthalmitis after cataract surgery, randomized controlled study, 16,000 plus patients, where rate of endophthalmitis reduced from 0.3 to 0.06%. That means there was 5 times reduction. Concerns with cefuroxime are emergence of resistant gram-negative isolates, higher visual loss in cefuroxime injected patients, and it has to be compounded in pharmacy. Vancomycin, on the other hand, was also used earlier, but there was a concern of hemorrhagic occlusive retinal vasculitis, and this was reported in this study, and so its use also became increasingly less. Intracameral moxifloxacin is available as preservative-free preparation, 500 micrograms per 0.1 ml. And this was a retrospective study from Arvind Eye Group in more than 1 lakh patients, where there was 4-fold decrease in the patients undergoing manual SICS. This was analysis on 6 lakh patients, where significant rate in endophthalmitis occurred from 0.07 to 0.02%, which was 3.5 times. And in PCR, the rate was increased by 7 times when intracameral moxifloxacin was not used. And it decreased to 0.21% where in PCR cases. Now, this is the study from Japan, 19 clinics, and this study I'm quoting because it is outside of India, where again this showed that there was 3 times decrease of endophthalmitis with no TAS reported. Now, as far as the safety is concerned, you have to look at the endothelial cell loss and the pachymetry, and in 65 eyes there was no significant difference which was noted, and this was a randomized control trial, 57 eyes, again no adverse event in terms of visual acuity, IOP rise, endothelial cell loss, pachymetry, or AC reaction. Now, this was the first survey which we did in 2017, 4,292 AIOS members who responded, which is a fairly good response, 30.2%. And when we compared it with the ASCRS survey, we found that there was similarity in decision for pre and post-op antibiotics, but dissimilarity in the choice of intracameral antibiotic and decision for subconj. So from our continent, people were still giving subconj, and we see the difference between the two surveys in intracameral antibiotics. We find that ciforaxime was given more by the ASCRS survey and moxifloxacin more by our survey. Now, again, 17 study, more than 9 lakh eyes favored the use of intracameral antibiotics, and this is the only, in fact, randomized control trial which is done prior to our study and which has 3,000 eyes. And although it did say that there is the incidence of endophthalmitis was 0.05% in moxiflox group vis-a-vis 0.38% in the control group, the numbers are not as high and the power of the study was not that great. This was the second survey that we did from the AIOS, and again we concluded that intracameral antibiotic prophylaxis for cataract surgery significantly increased in India from 40% in 2017 to 58% in 2022. And we actually did this randomized control trial in 60,000 patients, and this was done because in ESCRS actually planned to do it, but because of lack of funds they could not do it, and then in between the COVID came. So we started this study prior to COVID, had to suspend it during the COVID, and then further continued this study. As far as the aim of the study was concerned, it was in a randomized study to see whether intracameral moxifloxacin 500 microgram per 0.1 ml helps. And the sample size was collected, and each group recruited 30,000 patients. So we included 3 tertiary eye care centers, RP Center for Ophthalmic Sciences, AIIMS, New Delhi, Sadhguru Netra Chikitsalaya, Chitrakoot, and Tirupati Eye Center, Noida. And this study was in fact conducted from 2018 to 2024. 2 years hiatus was taken because of the fact that COVID was there. We included all cases undergoing phaco and IOL, age more than 40 years. And patients underwent phaco with IOL implantation. So topical moxifloxacin was given preoperatively. Povidone iodine was used. Group 1 had intracameral moxifloxacin, whereas in group 2, only phaco emulsification was done. And the parameters which are noted here were actually evaluated both pre and intraoperatively. And of course, post-op, again, moxiflox, steroids, and tropicamide continued. Whenever there was a case of endophthalmitis, all the protocol as per the endophthalmitis in any group, if it occurred, were followed. Now, if you look at the baseline parameters in terms of age, gender, best corrected visual acuity, IOP, endothelial cell density, central corneal thickness, it was comparable at baseline. And so were the incision size, type, location, IOL optic size, haptic position, type, wound closure, and also the posterior capsular rupture incidence. 6 eyes in cases where intracameral moxifloxacin was given, vis-a-vis 16 eyes where it was not given developed endophthalmitis, and this was statistically significant. So the odds of developing endophthalmitis if you don't give intracameral moxifloxacin as per this study was 2.5 times as compared to the control group. This is to look at the age, gender, history of PCR, mean latent period, and presence of hypopyon and systemic illness as far as the endophthalmitis is concerned. And this is the data which is shown. In terms of microbiology, 2 in the intracameral group and 6 without the intracameral group were positive and for cultures. And as far as the resistance pattern is concerned, ciprofloxacin, gefloxacin, and moxifloxacin, 5, 3, and 2 cases were resistant to it. In terms of the visual acuity, IOP, mean endothelial cell density, central corneal thickness, central macular thickness, which was also evaluated in these patients, none of the values were found to be significant. AIOCMTC4, in between we found, did give an advisory on the concentration and on the amount of the moxifloxacin that one should inject, because if you do not do it in the correct dosage and the correct concentration, then there can be TAS present. As per our study, we did not find any TAS in our study. So again, the 2 different concentrations which are available are 0.5% and 0.1%. So to conclude, intracameral moxifloxacin is safe and efficacious in prophylaxis of endophthalmitis after cataract surgery. And additional use of topical antibiotics needs to be validated after cataract surgery. But having said this, we all are giving pre-op antibiotics, post-op antibiotics, and of course, if you give intracameral moxifloxacin, that increases the safety as far as the infection is concerned. Thank you very much for your kind attention.
Thank you, Dr. Namrata, for a wonderful presentation and quoting all these studies. So I would like to know from the audience, how many of you are not using intracameral antibiotic? So quite a few of them. So Dr. Ragini Parekh, what is your reason for not using intracameral antibiotic? Mike, please.
So initially we were very scared to use anything intracamerally because in between there were problems with drugs which were directly used intracamerally and caused TAS and all that. So we do use the drop post-operatively, but we are not using it intracamerally, sir. And yes, sir.
Does anybody else would like to comment? Why they are not using intracameral antibiotics?
So we have not used it intracamerally in thousands and thousands of surgeries. But what I feel is that to prevent ENDOF, there are not only intracameral drugs, but lots of factors which are involved, which need to be controlled, managed. I mean, surgery, cataract surgery takes 5 minutes. But before surgery, during surgery, after surgery, starting from the patient, I can talk on quality control for hours and hours because we used to do 2,000 surgeries at a time. So I do believe that it is not only the intracameral drug, but there are so many other factors which also help. But with newer drugs which are safer intracamerally, I think that would be an added safety.
Dr. Namrata, you would like to comment? A lot of people are not using intracameral antibiotic.
No, I think it is up to one's own discretion whether you want to use it or you don't want to use it. Some people are not using it, some are using it, some are using it only if they have a PCR. But this was just to validate a point whether the use decreases endophthalmitis or not. And this paper got accepted last week in Journal of Cataract and Refractive Surgery and was also awarded the best paper of the session in AIOCMTC4. But having said this, I think maybe moxifloxacin today, but maybe the drug might change tomorrow, because if resistance occurs to moxifloxacin, then what next?
Yeah, I think I would like to comment over here, ma'am. I totally agree with you. We are using at Center for Sight. We have been using intracameral moxifloxacin for the last, I think, 7 years now, and there's hardly any case of end-off. It has drastically reduced the incidence of end-off, and if you use preservative-free moxifloxacin, actually it doesn't cause any problem. Though there are isolated case reports of BAIT or the transillumination defects of iris. Have you seen any such case?
No, we did not come across any such
request Dr. Rajesh
effects.
to give his
But one thing is definitely there, that you should use it in the right concentration, and you should use the right volume. And now, because you don't have to compound it, earlier you had to compound all the other intracameral antibiotics, you can use straight from the vial. So the chances of it going wrong are less.
Actually, it's a fact that a lot of us, we are not using intracameral moxifloxacin, and I have also not used it for many years and never had an endophthalmitis. So as Dr. Ragini was telling, there are many other factors that govern, that that are related to the occurrence of endophthalmitis, which we have to take care. Having said that, over the last few years, I've started using intracameral moxifloxacin because now it's an era of litigation wherein people, even the opposite lawyer can quote articles related to this, wherein it has shown definite benefit of intracameral moxifloxacin. Now, once again, having said that, people have shown a couple of reports of TAS. Now, there's a very interesting study done, which has been published in, I think, Ophthalmology or JCRS. It was done by William Myers along with David Chang. And they actually gave the correct concentration and dosage of moxifloxacin. So what we have is 0.5% of moxifloxacin. That should only be injected, only 0.1 ml of 0.5% of moxifloxacin should be injected. And if we are using 0.1% moxifloxacin, which is not available here, but it is available in US, there the dose was 0.5 ml. Now, any amount which is more than 0.1 ml of 0.5% moxifloxacin, if you inject intracamerally, the risk of TAS significantly increases. So we have to be careful in the usage of drug when we are using it intracamerally in order to prevent TAS. And as I said, now this is an era of litigation wherein all these documents, all these papers, publications are available for all the lawyers. So just to play safe, and also there is some evidence that
I think there is evidence also now.
There's that's true.
Is one thing, but if
there is enough evidence that
I think Rajesh has really very
Mm-hmm.
nicely summarized, and Ragini Parekh has definitely raised a very valid point. And I personally feel the cause of endophthalmitis is the poor wound construction. And I find at least 50% of the people who do phaco, they don't make wound properly. They don't make a limbal incision. They are clear corneal and just 1.25 millimeter of this and leaving a leaking wound. Because when you are operating, at that time you are washed with the betadine, so much of fluid is going. At that time there is hardly any chance of bacteria going in. It is the post-operatively, the ingress of the fluid, when the cadaver flora is again there, when it is sucked in, it causes endophthalmitis. So I had no case of infection for many years, but at the same time, as Rajesh has very rightly pointed, this is the time of a medical legal time, and injecting moxifloxacin, I have found no side effect whatsoever till date. Only thing, when you are injecting, do not keep the IOP very high. There should be enough. If the IOP is very high, the fluid will come back. So it will reduce the concentration. So keep the IOP slightly on the lower side and inject more onto the deeper side, other side of the incision, so that the minimal leakage of the fluid and there should be adequate concentration inside the IOP. There is no need to try to put into the capsular bag, because that's very, very difficult and chamber tends to collapse. Just putting into the anterior chamber is good enough, and moxifloxacin as of now looks the safest option for us.
Not be more than 0.1
Yeah,
ml
0.1
because
ml,
studies
that's
have
the
shown.
standard.
Yeah.
So with this, I think
Thank you.
we go to the next talk by none other than Professor Rajesh Sinha. He'll be talking about managing dry eye disease post-cataract surgery. I think one of the most crucial talks of the day.
Thank you, sir. I'll be talking about post-cataract surgery
One
dry
point
eye.
I would like to add in the previous talk, that always use moxifloxacin, which is preservative free. Sometimes people take moxifloxacin
True.
which has preservative, then it can cause TAS.
Yeah, I completely agree with you. We had a few cases of TAS at RP Center OT wherein when we investigated, we got to know that the moxifloxacin that was used in those cases was not preservative free. So that is again, so two factors. One is preservative free and second is the amount should be not be more than 0.1 ml. So coming to post-cataract surgery dry eye, I have no financial interest. Now, we all are, we do cataract surgery and we always feel that the patient should have good vision. Till a couple of decades back, we were very happy when the patient had 6/6 vision and we never bothered about anything else. Later on, in the early 2000s, when we started thinking that the patient should also have 6/6 and N6 vision. So we started using bifocal IOLs. Then we started thinking that, the patient had a demand for, intermediate vision, the use of laptops, as we all are using progressive to, read the laptop. So then came all these full range IOLs. And now, currently, when we are implanting an IOL, which is giving a 6/6, N6 vision and good intermediate vision, we cataract surgeons are very happy. And whenever a patient shows that, we say, "Kaam ho gaya, it's a wonderful surgery done." But some of these patients, they are not happy. Why? Because they do have discomfort, they do have irritation, and we get irritated that you are having such a good vision, but you are not happy. But then it's a fact, because the patient has a very important problem, and that is post-surgical dry eye. These symptoms can be very irritating and disabling as well. And some of these patients can have good quantity of vision, but because of the dry eye, the quality of vision is not very good. So if you assess carefully the quality of vision, then you will understand that why patient is not very happy. And some of these patients who might be having borderline dry eye before the surgery, they are more at risk. We all know that LASIK does have a risk of dry eye. Why? Because it creates a flap and it cuts the neuronal loop, as we see here, which is important for tear secretion. The patients there's a significant number of patients who are dissatisfied because of dry eye after LASIK as well. However, we never felt that cataract also can cause so much of dry eye. Now, there are multiple studies now, and recently I was going through a meta-analysis also, wherein a large percentage of patients, a large number of studies were shown, wherein they had variable proportion of dry eye post-cataract surgery, but not a single study said that there is no dry eye following cataract surgery. So definitely ranges from 10% to up to 50-60%, depending upon the patient cohort as well. Because these patients definitely are at risk of developing dry eye. Why? Because most of these cataract patients are older and have higher incidence of dry eye in themselves. Some of these patients have severe MGD, and some of these patients are perimenopausal females who have, because of the hormonal disturbance, they are predisposed to develop dry eye. Some of these might be using anti-glaucoma medications as well. And cataract surgery per se can also cause dry eye. Why? Because it alters the curvature, so the breakup time gets altered. Then it makes incision. As we know that, LASIK makes the flap and, cuts the nerve. Similarly, when we make a clear corneal incision, we do cut the nerves because of the incision. And sometimes we want to make the patient very happy and, take care of the astigmatism by using LRIs, etc. In all these conditions, in all these situations, we cut the nerves quite significantly, resulting in dry eye. And this is a very interesting study which has shown that the area near the incision shows significant reduction in corneal sensation, as opposed to the area which is on the opposite side. So that shows that the incision causes reduction in corneal sensitivity. And this is a study which has shown that the breakup time significantly reduced in the post-op period, which continued till 3 months' time. So maybe that can give you an idea that probably if you have to treat the patient, it is variable, but maybe up to 3 months' time, if we can cover up, then that will take care. This is another study which has shown that there is reduction in goblet cell density also after cataract surgery, which may be because of the mechanical damage, it can be because of the drug toxicity, etc. And drug toxicity, as I said, is an important issue because some of these drugs, which we were discussing just now, they do have preservatives, and preservatives can be damaging to the ocular surface, and that can result in dry eye. So once the patient does have, most of these patients, they do have dry eye, so you have to treat the patient of dry eye. How do we treat it? We have to give artificial teardrop. I think now a large percentage of cataract surgeons have shifted to giving lubricant eye drop in the post-op regime in almost all the patients, and if not all, then a large majority of patients. So that is the reason is this, that people have realized that we have to give these artificial drops, and if possible, if we can use a preservative-free antibiotic, then that will cause less toxicity on the surface. Coming to the polymer in as far as lubricant is concerned, well, there is no ideal polymer. You can use anything. Carboxymethyl cellulose has been used for ages. Polyethylene glycol has also been used. But over the period, over the last 4, 5 years, 6 years, sodium hyaluronate has come up as a very good polymer because it has such a coiled structure that it holds water for a long period. And because it holds water for a long period, it provides good comfort. And what do we want in these patients? Because these patients have irritation, foreign body sensation, etc. So we want that the patient should not have discomfort. And so that's why sodium hyaluronate has come up with a good outcome in reducing the symptoms of the patient and increasing the comfort index. So that's why many of us have moved on to sodium hyaluronate as far as treating dry eye is concerned. Again, if the dry eye severity is low, we can use anything. Any polymer will do. But if the dry eye severity is a little on the moderate to severe side, it's better to use a drug which holds water for a longer period and which provides lubrication properly. So that is something which we can do with sodium hyaluronate. It is available in multiple concentrations. 0.18% is a concentration which is useful in the sense that it is retained on the surface for a long period. It does not cause significant blurring because a concentration which is available on the higher side of this is also there, but it does cause blurring. And very few patients have shown blurring with 0.18%. 0.1% does not show any blurring. But then 0.1%, with 0.1%, the advantage is that your frequency of drops will be lesser. So this provides a good balance as far as treating moderate to severe dry eye. Then there is surface inflammation as well, for which we may have to give topical steroid, which we normally give in the post-op period in the initial phase after cataract surgery. Cyclosporin drops and doxycycline capsule are also useful as far as reducing inflammation. Topical cyclosporin is again a very useful drug in reducing inflammatory mediators. So in summary, dry eye is, I would say, it's quite common after cataract surgery, and a lot of patients, they do not complain because in the immediate post-op, we do give these drops, some of these antibiotics, steroids, etc., which suppresses the symptoms related to dry eye. But some of these patients, they come after a month or so when you stop all these medications, and they say that vision is good, but I'm having watering, I'm having irritation, and this goes on for about 2 to 3 months at least. So it's always better and safer to prescribe preservative-free topical lubricants in the post-op period. What we can do is that we have to make incision, so the nerves will be cut. So the controllable factors are reducing drug toxicity and to treat preoperative dry eye. So if we can give preservative-free antibiotics, if we can provide a post-op lubricating eye drop which can retain water for a long period, that is quite useful. And if there is surface inflammation, we have to take care and reduce surface inflammation as well. So thank you very much for your patient hearing. Most important slide is this, that we have to counsel the patient regarding the use of these medications. Because if you are giving topical lubricants, I prefer giving it for almost 3 months in post-op period. So the patient might feel that I am putting medication, dawa dal raha hu for a long period. That is something which we have to explain, that this is not a medication, it is a sort of a surface improver, and we have to use it. So good counseling and a little bit of chair time is really helpful as far as the patient satisfaction is concerned. Thank you very much.
Thank you, Rajesh, and we welcome Dr. Lane over here. So is there anybody who is not using the lubricant eye drops post-operatively? So I think most of us are using the lubricant eye drops, and only discussion is for how long and how frequent we should use the eye drops. Is there a standard 3 times, 4 times, 6 times? We keep on varying according to the...
It again depends on the severity, but in a large majority of patients, 3 times a day is good enough. As far as duration is concerned, studies have shown that up to 3 months, in a large majority of studies, up to 3 months they have shown the requirement is there, because the denervation is significant enough up to that period. So although denervation is still there after 3 months, but it improves by that time. So 3 months is the cutoff which a large majority of surgeons and researchers have believed that it should be used for.
I actually tell my patients 6 months to 1 year, you will have the irritation, because otherwise patient keeps on coming every 2-3 months. So straight away day 1, the irritation will persist for 6 months to 1 year, so that it does not keeps on bothering you time and again. And use the lubricant eye drops for lifetime. I mean, I never ask them, it is like applying cream on your face, so you don't have to worry. This is just a lubrication. You don't have to be, after 3 months, you don't have to be very strict with the scheduling. You can use it 2 times, 3 times, 10 times, whatever is your comfort level. It has got no side effect whatsoever. So this is entirely your choice, and if patient can afford, can keep on using. So if it is a preservative free, it doesn't have any side effects, so I think it can be used for a longer period of time. Is there any role of treating pre-operatively these patients for starting the lubricant eye drops or cyclosporin eye drops pre-operatively?
Yeah, so any patient who does have dry eye, like we do breakup time in the, when we are evaluating the patient. So if breakup time is borderline or it's slightly on the lower side, it's always better to start using lubricant before the surgery. And some of these patients, they show subtle signs of inflammation. So if there is subtle sign of inflammation, we should start using cyclosporin in these patients also and continue. And although cyclosporin may not have an effect in the immediate, after prescribing immediately, but since we started, we can start it in the post-op period also, but because it takes about nearly 4 weeks time, 6 weeks times to take its effect. So by that time the steroid is already being put because of the post-op regime. So after that cyclosporin takes over. So any patient who has a borderline dry eye preoperatively, we should start preoperatively so that the patient does not come to us with complaints.
So many times these patients have advanced cataracts, white total cataract. You don't have that much time to wait for the ocular surface treatment. So that is one of the practical problems.
I completely agree with you. If there is an advanced cataract, go ahead and do a cataract surgery in 2 days' time. There's no harm. You can start it in the post-op period, because in the immediate post-op period, you will have topical steroid which suppresses all these symptoms. We have others, if you are using non-preserved antibiotic, that will also take care, because in such patients we should use non-preserved antibiotics. And lubricating eye drops in the post-op as well. So see, in 1 week time, you cannot treat dry eye. So I don't think waiting for a week just to think, to give a mental satisfaction to ourselves that we have waited for 1 week, it doesn't make sense. So you can do cataract surgery immediately, next day also, but in the post-op period also we can start giving topical steroid and cyclosporin combined along with lubricating eye drop in patients who had dry eye.
Only very important, many patients when you are doing the IOL power calculation look at the cornea over there.
Yeah.
And even 1 day of treatment can change the corneal power significantly.
Yeah.
Particularly if you are going to use the EDOF lenses and a toric IOL. I have many patients just treated for 2-3 days and cornea was stabilized. So it's very important to treat the dry eye for getting the very accurate IOL power if you are going to use the premium IOLs. So don't go for the averages. You get a chart, averages are there, look into whether all the access and all the powers, and on a 2 machines, Pentacam and IOL Master are the same or not. If you are finding any variation, please do treat the patient for the dry eye. Even for 48 hours, you will find a huge difference. Call the patient. Till the time cornea is stabilized, don't go for the final EDOF lenses or final toric IOL. So make sure that your keratometric values and axis are same on 2 different equipments before you decide for the IOL. So very, very important to treat the dry IOL, particularly when you are using the premium IOL.
Yeah, that's a very, very, very valid point. We have noted this thing in our own case series, and that's a very valid point.
And another, I really don't know, Rajesh, I would like to know from you and from Dr. Elhane sir. When we used to do ECC and IOL, there was hardly any problem of dry eye. I mean, the lubricant eye drops were not available at that time, and hardly any patient used to come and complain about the dry eye. Now we are doing such a fine surgery, and still patients keep on complaining about the dry eye. Ragini
It's
wants
more
to say
related
something.
to
Yeah.
Sir can say and then I'll talk.
Yeah.
Sir can
Basically, this is the recent advances in the human beings. So that has happened. So these advances are that, yes. So they want the drug to be used. So we are using the artificial tears. And just now I have published this one that 65% patients who are coming to me in my clinic are having the problems of the dry eye. It means they are coming with such type of, maybe some dry eyes are there. Before that it may be there, but our knowledge was not there. That is maybe that.
So what Sir is saying is very true, that these are the observations that we have, that so many patients in our clinic have dry eyes. In fact, the Shermer's is 5 millimeter, 6 millimeter. I think it is all the digital strain, which was probably not there in our era when we were doing ECC. And also the companies are promoting only dry eyes drops, which is rightly so, because I think the future generation of ophthalmologists will forget ophthalmology, because I would say more than 60% of our patients have digital strain and dry eyes. So the new generation will forget every other disease.
Actually, Shermer's comes normal in these patients. I mean,
That is
the
a
patients have
reactive,
symptoms.
reactive watering sometimes causes a wrong or a failed Shermer's test. But so many dry eyes, I think it is nothing to do with the cataract surgery. It is all to do with our lifestyle.
I'll just add 2 points on this. I would like to add 2 points. One is that there's a very interesting study. I had hidden that slide to reduce the number of slides. There's a very interesting study comparing SICS versus clear corneal temporal incision phaco and occurrence of dry eye. And in SICS, they found out that the corneal sensation was better and the occurrence of dry eye was less. The reason is this, that you are not making a clear corneal incision. You are making a limbal and post-limbal scleral incision. Similarly, for ECC, we used to do a peritomy and make an incision posteriorly. So there we were not transecting the nerves that much. That is one. Point number 2 is that in the era of ECC, we were struggling to get a 6/6 or N6 vision, which now we have succeeded in getting that. So obviously other things come after that. So patient having symptoms in spite of good vision, quality of vision is coming after that, after quantity. 6/6, but the quality is not that great, so because of the dry eye. So that's how we evolve, and that's natural.
So I think there are 2 factors. One is probably covering the wound with the conjunctiva, probably maybe making the trick for ICC, and even the patients we do trabeculectomy don't complain that much of a dry eye as compared to the clear corneal incision phacoemulsification. And secondly, the excessive use of the mobile and a laptop, which we are using constantly. And third, of course, the patient is seeing 6/6, 6/9. He has to complain about something, so he complains about watering and a dry eye. So, but in any way, we have got to take care of them. And we move on to the next talk by Dr. Ragini Parekh, Professor Dr. Ragini Parekh. Same molecules, different story, innovator versus generic.
Can somebody my talk? So respected Padma Shri Dr. Lahane sir, respected Dr. Harbanslal sir, Dr. Gupta ma'am, Rajesh Sinha. नहीं यहाँ पे लोड किया होगा ना? नहीं? You didn't load the talk. Ashok sir, can somebody do the talk till my talk is loaded?
लोड नहीं किया है?
नहीं, actually I thought it would be loaded.
We'll invite the next speaker. A reflective revolution, unveiling the power of PRK, Dr. Gaurav Gupta.
काय झालं? आता करता येईल.
A very good morning to all. At the outset, I would like to thank AIOC to give me the opportunity to speak on a refractive revolution, unveiling the power of PRK. So PRK is basically photorefractive keratectomy in which epithelium is removed and then direct surface ablation is done with the help of excimer, which is basically a flapless procedure. PRK is traditionally being done manually, in which the epithelium is removed manually. Then the alcohol-assisted PRK came, and now the latest is the transepithelial PRK, which is popularly known as the touchless laser, because in this epithelium is also removed with the help of laser. So common indications are myopia, hyperopia, and astigmatism. So I'll be demonstrating a quick video of procedure of PRK. I practically feel it is the most easiest of all refractive procedure, in which well is used and 20% alcohol is placed for 30 to 40 seconds to loosen up the epithelium. And then alcohol is dried and wash is given.
talk करके आता हूँ मेरा.
And this epithelium very easily comes off. We can remove almost 8.5 millimeters of epithelium, and we dry the surface, and we just directly fire the excimer laser after focusing it. Like here we have focused the mass and the excimer fires. So basically it is a very simple procedure and very easier to learn, and I personally feel among all the refractive procedures, PRK has the least learning curve. If someone is doing a routine, any ocular surgery, and in rather 2 to 5 cases, they can easily learn the procedure. And then the MMC is applied, and thorough wash is given, and BCL is applied at the end, and the surgery is done. So there are a lot of advantages. As I said, it has least learning curve, easier to do, safer, least chances of complications, can be done in thin corneas, steep corneas, or borderline cases, and even can be done for very low powers. And there are very less chances of rise, as we are not cutting anything, we are just removing the epithelium. So like this case, this is a case in which the power was low, 1.5 diopters, and the cornea was thin, and on Belen Ambrosio there was borderline topography. So such cases are very good for PRKs. This is another case with 5.25 diopter myopia, and topography is fine, but the cornea is thin, 490 micron. This case is also a very good case for PRK. So PRK has shown very superiority in cases with thin corneas, low myopia, and steep corneas. So it is very effective in these cases. So in PRK, what we don't want to happen, the vision should not drop, there are chances of corneal haze, ectasia should not happen, post-op infection, aberration or glares, and regression. So these problems can be very well dealt very easily. So coming to the literature, so PRK in thin corneas, we have seen that post-ectasia risk can be calculated with the help of ectasia risk score system, and the score is less than 2 points, then there is low risk. So we can see at 2 points, the residual stromal bed thickness can be kept up to 260 micron, but I personally feel we should not go lower than 300. And also in borderline thin corneas, up to 480 micron we can go in these cases, and also in borderline topographies too. This is another study showing photorefractive keratectomy in myopia and thin corneas, and they found that at 1 year follow-up, there was no haze, or a very limited haze, and the visual outcome was good, and even if done in thin corneas. There's another study showing it is safe and effective in thin corneas. So coming to the corneal biomechanics, nowadays a lot of talks is about, as we all know, that PRK has superior biomechanical strength as compared to LASIK-based or flap-based procedures, but comparing it with SMILE, and there is a study by Professor Namrata Sharma et al. And they found that PRK has superior corneal biomechanics as compared to SMILE as well. And it has better biomechanical strength as compared to femtolisic as well. So still we need to take some precautions in thin corneas. We should try to maintain residual stromal bed more than 300 micron, but if the topography is fine, we can go lower than that also. Preoperative corneal biomechanics, if we have facility, we should check and avoid correcting very high refractive error if there are thin corneas. In low myopia also, we need to understand what is the difference between undercorrection and the regression. Undercorrection is something which has not been treated, like if there is residual power at 3 months. And regression is something if the power has been treated at 3 months and then the number comes again. So this is the major difference. And this was a study which published in Cornell recently comparing the risk factors of keratometry, myopia, astigmatism for myopia regression specifically, and they compared with PRK, a lenticule-based procedure, and the LASIK. And they found that it was a big study comparing the data of 2,781 eyes in which the regression happened, and they measured regression by 0.5 diopter at 1 year. And they found that the regression was maximum in SMILE cases, and if the keratometry is steeper, then it was more, and it has a minimum chance of regression in cases of PRKs. So similarly, in steep corneas also, if the cornea is steeper, there is no significant difference in PRK cases. So to prevent, like we all know, with every procedure, there are some things which are drawbacks. So main problem which PRK has been restricted is due to the postoperative pain. So for that, we can use intraoperative chilled balance out or topical NSAID or oral analgesic or use of BCL. Corneal haze is a major problem in few cases. So for that, I personally feel use of MMC is must in these cases, and avoid correcting more than 6 diopter and astigmatism more than 3 diopter. Epithelial related complication like the vision do not clear us up immediately after the surgery, and it usually take 2 weeks to 3 weeks and sometime up to a month to clear up. So delayed healing is a problem. And few cases also develop glare and halos. So my take home for today is that PRK can be safe in thin and steep corneas in low myopia, and considering safety parameters, always assess corneal topography and exclude subclinical ectatic cases. Avoid correction with high refractive error. Always assess corneal topography, and PRK can be augmented with extra procedures. Thank you.
I request Rajesh Sinha to give a comment on that, PRK versus.
Yeah. Thank you. It was really a nice presentation, and PRK definitely has a good role. But I mean, a lot of people, they don't do PRK because of some element of risk of haze, and studies have shown that nearly 1/3 of patients, they do have some haze which may be significant or insignificant visually at that point of time. So that is one reason why some of the people, they avoid. But after this modification of using chilled BSS, using a bandage contact lens which has already been refrigerated for a long period, the the chances of having post-op pain and risk of haze has also reduced in these cases. So in our scenario, what we have felt is that we do mostly we do LASIK or SMILE, but we do PRK in conditions wherein the cornea is slightly on the thinner side, but there is no evidence of any FFKC. So in such cases, we do PRK.
Thanks, sir. Very well pointed out.
I think let's go on to the next talk. We are running short of time.
Just a quick question from sir. How do you treat early post-PRK haze? If you see haze at 3 to 4 weeks' time, what is your first line?
See, first line of treatment will be use of topical steroid only in order to reduce haze, and along with that, I add some either cyclosporin, or these days I have also started thinking of using these liftegrast. There are a couple of reports wherein liftegrast has reduced the density of haze post PRK. So maybe we can use topical steroid and liftegrast along with that. In the immediate post-op, early post-op period. Later on, if the haze is there, it persists, then obviously we have to do a PTK with MMC and all that. Topical mitomycin C, I will avoid using in these. Rather, if it persists and it is a visually significant haze, then I may just do a little bit of surface ablation with use of mitomycin C for 45 seconds to 1 minute.
Okay, thank you. Now we come to the last talk of this session, and Dr. Ragini Parikh will be talking about the same molecule, different story, innovators versus generic.
Thank
Dr.
you so
Ragini
much, sir. So this is a very important thing in our lives. We use drugs every day, but do these drugs act? You know, we've seen, I've seen a film when I was very small where some drug was given and it did not act and the child died, and it remained with me all my life. So even today when I am working, I always think of that. So it's the same molecule, but is it a different story? So my talk will be innovator versus generics. So the success of a medical therapy depends on many, many things. Whether the drug is efficient, what are the side effects of the drugs? Many drugs are very good, but because of the side effects, like if you give acetazolamide, patients hardly take it. Patient compliance is, of course, very, very important. In our lives, cost is very important, and the quality of the product is extremely important. Now, the product quality depends on the variability in the active ingredient concentration and the product packaging, that is the bottle material and the drop size. Not only that, last week I got the shock of my life because the patient was not able to open the bottle and they were using safety pins and everything. So now we started opening the bottles and giving it to the patient. So these are things which are out of your control and you don't know what is happening behind your back. As therapy becomes increasingly costlier, therapeutic decisions are often economic, which is very true. I worked in a government hospital for 31 years where economics played an extremely important role in my life. And so generic products came into being and they are now considered to be an essential part of the treatment paradigm. However, it is of importance and great importance to know whether the innovator and generic drugs can be used interchangeably. So many a times a patient always tells us, that this drug is very expensive. My friend is using another drug which is much cheaper, especially for people of dry eyes or glaucoma who are on long-term treatment, and finance would play an important role in their lives. So what is an innovative drug and what is a generic drug? Now, innovation is a person who first made that drug or innovated it. They are prepared through research and they go through rigorous clinical trials and regulatory approval before marketing. Because it's a new drug, there is so much that is required and so many layers of approval before the drug is accepted. So much research goes into it. So much money is spent on that. And hence, when it is new, that's the only drug in the market and it is costlier, because you have to cover the cost on studies, research, marketing and all. What happens to the generic drug is after the innovator has got a patent, then other companies or any other people also start manufacturing it, and it is intended to be the exact duplicate of the innovative drug, and they rely on the safety or the studies which are made by the innovator and the effectiveness information, okay? Now, the cost is reduced because they don't have to go through all the layers or all the everything that the innovator company went through, right? So, again, what is the difference between the innovator and the generic drugs? So, it is a patented molecule. They have the patent, they got it, they made it first, and it's a copy after the patent expires. To get permission from the FDA, the innovator has gone through rigorous safety and efficiency trials, and hence the side effects are low because they've tried to do more and more. So here, the bioequivalent studies are enough, and maybe that they may have higher incidence of side effect. Particulate matter in the formulation is lower, the quality is higher, and cost is definitely higher. So here the particulate matter may be higher, the quality may or may not be lower, and the cost is definitely lower. So for us or for the patient, like the patient comes and tells us, Kiri, this is so expensive, I'm getting I'm getting the same molecule but at a lower cost. So FDA requires generic drugs and their innovator components to be bioequivalent, okay? That means they must have the same active ingredient, strength, dosage form, and the route of administration. So, like we know, okay, if you say a certain drop, 0.5%, same, and companies are different. Now, what is bioequivalence? It demonstrates the ingredients of the generic version which are exact copy in the original drug, right? So, that actually, ideally, it should have the same safety and efficacy. But is it actually so? Does it actually happen? And it's not because it was not intended to happen, but because they have to go through less safety, it happens. Okay, it's not that they want to make a substandard drug or something substandard like that, okay? So, unfortunately, the idea that generics are equal to branded medication is not necessarily true. So why is it not true? What actually happens is that there may be changes or discrepancies in the manufacturing process. There may be inactive ingredients which have the buffering agents whose pH might be different. The drop size and the container would be different, and there would be difference in the preservatives. So this we never looked at. That though the active ingredient is same, say stimolol maleate, but what about the bottle, what about the drop size, what about the preservative? And these 3-4 things, do they affect the way the drug would act? They would. So they would lead to different pharmacokinetic characteristics, absorption and bioavailability of the active agents at the site of action. So even I never thought, for so many years, I used to always feel, okay, this is expensive. Now that this has come into the market, because they manufactured it first, it was expensive. And I used to always feel that they have a monopoly. They were the only ones in the market, and that is why it is expensive. So that is what it was in my mind till I went through this, and I realized that that's not the only factor as to why it is expensive. And does cheap or a generic drug mean the same? And for a patient, would it be the same? So they may not be therapeutically equivalent. And studies have shown that patients who have switched, they have decreased clinical efficiency and increased side effects, okay? So these are the studies which say that if you are shifting from a innovator drug to a generic drug, the efficiency may be lower. It means that in one study, there was a significant rise in IOP. In innovative drugs, the side effects will be lower, saying in a study, the patient had less irritation, and in a generic drug, there would be more punctate keratopathy or congestion. So then again, active ingredient. See, basically when you give a drug, what happens to the active ingredient and what actually acts at the site is very, very important. So loss of active ingredient, if it happens, then your drug will not act. So quality with low particulate matter. Particulate matter, the patient always complains of concentration or white particulate debris and all that. So that is also important. And these debris or higher molecules can cause ocular irritation, okay? So this is an Indian study which shows that the innovator outshines the generic travoprost in quality of formulation. So as you can see over here, the innovator would be better in quality with respect to drug concentration and osmolarity, impacting the absorption, efficacy, and side effects. Okay? So it so happens that only the innovator met the USP drug concentration standards. So if the drug concentration exceeds the label amount, side effects will increase, right? And if it is lower, then the potency could be compromised. We never think of that the active ingredient is higher, there will be more side effects. If it's lower, then your purpose of giving the drug is not served. So again, innovator transcends the generic travoprost with reduced goblet cell damage. So if there is goblet cell damage by a generic drug, the patient would complain of severe dry eyes. And if you can see, there is more damage of giant cells with the generic drug. Now what would happen is that this is less. If you see many patients who are on this drug, we tell the patient, ki, see, having redness and irritation is a part of this drug. And we assume that it is a normal part, right? And we give the patients, before we start the patient on this drug, we give the patient artificial tears and all that. But we never realize that it could be because the drug is generic and it is causing more loss of goblet cell. So I think we can, and it's very easy for us to try out in the same patient at different times or in different patients. In fact, same patient, 2 different drugs will also help us come to a good conclusion. So definitely giant cell damage affects the tear secretion and the ocular surface disease becomes more prominent. So the pH also changes. See, pH changing definitely affects the health of the tears. It would not matter, like say in a post-op patient or a person who is on a week's treatment of antibiotics. But in a person who is on long-term treatment for glaucoma, definitely if the pH changes and the tears changes, his ocular surface would change, which is not good for the patient. And hence, you have to have a drug which has a closer pH to the tears and which is tolerable by the patient. So it outperforms in terms of pH, which is very, very important in the long run. So the cost always is the problem, and we always go by cost. I think somehow or the other, we definitely, and we should, why not? I mean, I've remained in the government and cost remained a big part of my life. Now in my private practice, patients laugh at me sometimes when I'm trying to save their money. And, so cost is definitely important. Cost will always remain different. And shifting from a branded to a generic drug usually saves considerable cost, which is very attractive sounding to the patients and to the surgeon itself. However, switching may have multiple concerns, overall affecting the cost, patient adherence and outcomes. So you may shift to a lower financial cost drug, but at what cost? That is also to be thought about before switching, or if you have more side effects or if the patient is going to suffer more, then is it worth it? So impact of switching may lead to affect problems with the pharmacokinetics, decrease efficiency, increase adverse effects, increase doctor's visit, impacts cost of therapy and affects patient compliance. So in the long run, if there are more side effects, it may affect the patient compliance, the doctor's visits may increase, so maybe your cost factor, and even if it is financially more expensive, if the patient compliance and if the patient health is better, then why not? Can I take a minute more? So innovator drugs are tested more. That is true, because for FDA approval, they have to go for more rigorous testings, which is very, very correct. And so they are related with lesser side effects. So there may be more side effects like irritation, conjunctival hyperemia, which we have seen. They have fewer particulate contaminants, and because of that, and also the bottle material compatibility is more, because when you are going for FDA approval, the bottle also matters. So here, but the bottle material may never be tested, and they may use any bottle, which may not be correct. So the innovator dosing is more reliable, so the drop size is more consistent. So the bottle is designed in such a way that there is an effective drop size. Now in the long run, if your drop size is effective and you are using lesser drops, if you are using more drops with a cheaper bottle, you may use 2 bottles. So ultimately the cost may come the same. So the drop size is very important in expensive drops, because the drop is only 3 ml, suppose, and you have to tell the patient that you have to be careful. So these bottles are very patient-friendly with proper squeezability, drop size, and especially for elderly patients. And you have harder bottles and inconsistent openings leading to poor compliance. I've already said it. So the choice of drug may be customized. So if you have a patient who is affording, that is very, very true. I think this slide is extremely important, that they are not, in this slide, we are not saying that you use only this or that, but you must see if the patient is affording, then definitely an innovator drug would be more important for this patient, and it would be, actually should be the first choice where cost is not a factor and efficacy and safety are of concern. Also, switching are not from generics to innovator from generics where endpoints are not reached. So if the patient is not affording, definitely, because if the patient is not affording, he will not buy it only. So you have to think of generic drugs. So that is very, very important, but you have to keep in mind that there may be side effects and there will be decreased efficiency. So these are the drugs which are these are the drugs which say Travitin, Travacrom, Simbrinza, which are innovator drugs, and that is why they remain expensive. And I think that this presentation not only helped me bring it out to everybody else, but to myself also, that as to why the drug is expensive and it should remain my first choice. I think I can try more and more. I would like to thank Snehal and everybody for this talk and opening our eyes to drugs. And I like the slide which says best, that use what is best for the patient, even depending on the money. So you may have to make a difficult choice. Thank you so much, and I'm really sorry to overrun my time.
As you are late by a few minutes, so we'll conclude over here. And thank you very much to all of you.
So stay on, for the best of the best session is next, just after the photograph of the stalwarts. AV, aa jao bhai.